Joining us to discuss disparities in cancer is Dr. Edith Mitchell from the Kimmel Cancer Center at Thomas Jefferson University and the Thomas Jefferson University Hospital in Philadelphia, PA. Thanks for stopping by to visit with us.
Well, thank you. Thanks for the invitation.
Let's talk about an overview of disparities, what they are, what type of work you do.
Well, disparities refers to differences in either the incidence of cancer or the morbidity or mortality or other avenues of cancer where there are differences in people that cannot be explained by just routine kinds of issues. For example, there might be differences in access to care, differences in insurance rates. But more recently, what has been demonstrated is that there are actually differences in the diseases, differences in molecular features or biological features of the disease that cannot be explained by routine measures. So therefore, there is a lot of research ongoing to try and explain some of these differences. So if one looks at differences in cancer rates, for example, how often does cancer occur among blacks and whites in this country? African Americans have the highest incidence of cancer that occurs in this country. In fact, black men have the very highest of in a single group. And yet, for each disease state, there can be differences. For example, in prostate cancer, African American men experience prostate cancer at much higher rates than Caucasians. They develop the disease at an earlier age, below age 50, have a more aggressive form of the disease, and then die of the disease at much younger ages than in other populations. Breast cancer, another area where there are tremendous disparities. For example, our research and the research of others has shown that African American women have a lower incidence of breast cancer, but yet have a different disease in that the death rate in African American women is about 15% higher than Caucasians, despite having a lower incidence. And there are differences in the biological and molecular features of the disease. For example, African American women have twice the rate of triple-negative breast cancer. And what that means, triple-negative breast cancer is a more aggressive form of the disease. It occurs with more rapidity. Patients develop recurrence or spread of the disease much more rapidly. And because the receptors are all negative, there is the lack of effectiveness from the usual treatment modalities. So the treatments that for many decades have actually shown benefit, such as tamoxifen in estrogen receptor positive disease. In triple negative disease, tamoxifen is not effective at all. So therefore, African American women have twice the rate of triple negative disease, which means the disease occurs at an earlier age. It is more aggressive, spreads more rapidly, and there are fewer medications that show benefit or effectiveness. So therefore, there are tremendous disparities in breast cancer in this country. Another, colorectal cancer. Colorectal cancer occurs with a much higher frequency in African American, both men and in women, with about a 20% higher incidence and an approximately 40% higher death rate. So that for colon cancer, what we see is that colon cancer occurs at a much younger age in both African American women and in men. And the American College of Gastroenterology, as a matter of fact, have recommended that African Americans begin screening for colon cancer at age 45 rather than the generally recommended age of 50. And that is because there is about a five-year age difference with African Americans presenting at about 5 years earlier. It also has a more aggressive disease, and African Americans are more likely to present with late-stage disease. And late-stage disease is more challenging to treat in any group of individuals or in any individual patient, but African Americans in general will present with more advanced or late-stage disease. So therefore, there are many efforts to try and address this disparity by screening with the hopeful intent of identifying patients at an earlier stage. And the earlier the stage at diagnosis, the better the likelihood of a really good outcome. Not only do African Americans have a more aggressive disease that spreads more rapidly, tends to recur much sooner after surgical intervention, but some of the medications that we find that are generally used throughout the world might not be as effective in African Americans. For example, we did a study in the Eastern Cooperative Oncology Group, ECOG 3200, with oxaliplatin 5-FU and leucovorin, or FOLFOX as it is called by its nickname. FOLFOX is the most commonly used chemotherapy regimen in the world for treating either metastatic colon cancer or in the adjuvant setting, meaning that the chemotherapy is given after surgical intervention. And what we found in ECOG 3200 was that African American patients did not benefit as much as our Caucasian patients from this therapeutic intervention. So there are multiple research areas for evaluating disparities and trying to find some of the answers that will allow us to develop therapeutic interventions and solutions that hopefully we will be able to address these disparities. Because to summarize, despite cancer mortality decreasing in this country over the past 2 decades, the actual gap between the races has increased. That gap has not been closed. So hopefully research will allow us to better understand the causes of the disparities so that they can be appropriately addressed and will allow all Americans to benefit from some of the therapeutic interventions that have been discovered in more recent years.
Doctor, do these gaps prove there needs to be a greater focus on research in disparities?
Well, if you're asking me, and I do research in disparities, of course I'm going to say that we do need to focus more of our resources into trying to explain differences in response to medications, differences in metabolism of new drugs, but also increasing access to clinical trials because there are many social as well as economic issues that prevent certain individuals from participating in clinical trials. So yes, we need to increase participation in clinical trials so that we are able to identify and address those issues that could have a relationship on success in clinical trials or treatment modalities that might affect different individuals in different ways. For example, there are some compounds that women may metabolize differently from men, or ethnic groups may metabolize in different forms.
Doctor, you focus primarily on two cancer types, breast and colon cancer, and you look at the differences between men and women and blacks and whites. Can you tell me what disparities have you found in those groups in terms of participating in clinical trials?
Well, there are a number of differences. For example, one of the areas has been increasing the number of practitioners from racial and ethnic minorities. Certainly, the number of black physicians in this country has not changed significantly over the last 30 years. So increasing the number of practitioners of minority groups will be important. Encouraging and helping members of minority groups participate in clinical trials. For example, many individuals who are of African American descent prefer not to participate in clinical trials based on historical perspectives, such as the Tuskegee incident. Tuskegee has not been forgotten, and many individuals let you know about that, and consequently there's a lack of trust in the system that prevents many individuals from participating in clinical trials. Also, there have been studies and research conducted on the practitioners, in that in the same hospital, patients who are different might be offered different treatments based on a number of factors. So making sure that we provide the right medical care at the right time, the right screening test for individuals. So there are multiple factors that certainly research has shown could contribute to the disparities.
Dr. Mitchell, thanks for visiting with us. I really enjoyed it.
Well, thank you so much for the opportunity to speak with you today.
Good. We bring the differences out into the open, and hopefully you can find a way to bring all of these different people together for a cure.
And hopefully we'll get more patients participating in clinical trials and more research addressing disparities in this country.
Thank you. Dr. Edith Mitchell.
Thank you.